Okay, hello everyone. Once again, welcome to the first affiliated hospital of Harbin Medical University. Today, as you can see, we are making this live case demonstration in the new branch of our hospital, which is located in the Qunli branch. And as you can see, our favorite operator, Professor Gong Yongtai, is going to perform a very complex and also very interesting case for us. And Professor Gong, maybe you want to say hello to the audience.
Hello, everybody.
Okay, Professor Gong is also working on the patient. So next one, I'll introduce the general information of this patient. Again, our leading operator for today is Professor Gong Yongtai, who is also on a high volume and very experienced operator. The second operator for today is Dr. Sun Danghui, Dr. Zhang Hongwei, and Dr. Liu Lei. I'm the moderator for today. I'm Dr. Cao Yang. Next one, please. Okay, as you can see, the patient for today is a 56 years old male with the general body size. And also we can see that there are several risk factors of this patient. He accepted PCI 10 years ago due to the old myocardial infarction. And he is a relatively very heavy smoker, and he has a history of smoking for 20 years. And recently, the patient complained about the chest pain under labor during the previous 4 months, and we can see that this is the chest pain of stable angina pectoris. And the echo indicated that there is no left ventricular wall motion abnormalities with the EF value of 70%. Next one, please. So this is the ECG for this patient under the admission of the hospital. So we can see that this is standard rhythm and also lead inferior with the lead 2-3 and AVF. We can see the QS form, which indicated the inferior wall damage. However, we need to check the old myocardial infarction, which is the location. So next one, please. This is laboratory data. We can see that troponin I is within the normal range. So our diagnosis for this patient is stable angina pectoris, old myocardial infarction, and hypertension. Next one, please. Okay, this is all for the general information of the patient. So next, maybe Professor Gong is going to introduce the angiography for today.
Okay. Firstly, I will show the result of angiography. Okay, let's see the left coronary. You can see the stent in the LED and in the next. You can see in the stent in the LED proximal to middle segment, and there is also a stent in the first diagonal proximal segment. But in the ostium of the first diagonal, there is significant stenosis. Another. Okay. You can see the stenosis is very severe.
And also focal.
Yeah, and focal. But the first diagonal is very long. For this lesion, we should perform functional assessment by FFR to evaluate the significance of the stenosis and decide to if we should perform a PCI for this lesion. Okay, next. We can so the collateral from left coronary to RCA, and the RCA vessel is very big, and we can see the collateral from circle flags and from LED to the RCA.
Mhm.
Next, for RCA coronary angiography, you can see the proximal chronic total occlusion.
Mhm.
For this patient, he had the chest pain more than 4 months.
Mhm.
So I think the leading of the proximal RCA may be the occlusion leading may based on the significant stenosis and then occurs um, a, a plaque erosion or plaque rupture
Mhm.
and then induced the total occlusion.
Mhm.
Next, of course, we should perform RCA PCI
Mhm.
to recanalization the vessel and the guidance of the dual injection
Mhm.
or collateral injection. We try the first line cross to the cross the leading from the anti-grid
Mhm.
approach
Mhm.
and with the cochlear microcatheter and our initial Y choice in the field XT for its the tape of the Y is very soft
Mhm.
and it's a tapered shape.
Mhm.
Uh,
Dural core, yes,
yes,
design. Mhm.
and because the length of the occlusion is very short, I think I think it can be quickly crossed by the anti-glide wiring technique. Fortunately, and the first Y, as we used the field XT, significantly successfully crossed the lesion and was uh, delivered to the distal true lumen. Yeah,
Mhm.
this is the distal Y location and from the anti-grade retrograde injection, we can um, confirm
Mhm.
the Y location is the distal true lumen.
Yes.
Uh,
Mhm.
then the microcatheter was uh, delivered or was pushed to the distal segment, and then the tip injection was performed and to confirm the true lumen again.
Mhm.
And next, we exchanged workhorse Y and then complete balloon dilatation. Of course, after pre-dilatation, we finished IVAS imaging. Uh, please, Professor Chow, can you show
Okay.
the
Mhm.
first run for the IVAS result?
Okay. So thanks for the introduction of Professor Gong, and we see that after the integrated approach using an fielder family wire that we successfully, penetrated through the fibrous cap, and after switching to the workhorse wire, and we use a 2.0 balloon to make some pre-dilation. to make slightly plaque modification to try to help the IVUS catheter to pass through, and then we make this pullback. It's a relatively long pullback, so we focus on the proximal occluded segment. So at the beginning of this pullback, we can see that it's almost in a 3.5 vessel with almost no plaque as the proximal part distal to the occluded segment. And also as the IVUS catheter is pulling back, we can see some eccentric, fibrotic with some a little bit, maybe I think that's a calcified lesion within the plaque. However, it's not so, heavy because there is not a very heavy attenuated plaque. We can see some plaque control dissection and also very heavy plaque burden with eccentric, and also maybe due to the 2.0 balloon dilation caused some intima dissection. And this is the proximal segment. From the bilateral angiography, we notice that the occluded segment is not so long. So according to the IVUS, it's maybe 28 to 30 something from the length. And something we need to notice is that we can see here, which is the most severe part within the occluded segment. The plaque burden is very high, and also it seems to be very heavy fibrotic and calcified lesion. So maybe some very wild, modification of the plaque is required. Maybe some scoring balloon or cutting balloon is required. So this is what we see from the IVUS pullback, Dr. Gong.
Okay, thank you, Professor Chow. Based on the result of the IVUS, as we know the heavy plaque burden, then we choose a cutting balloon,
Mm-hmm.
3.0 cutting balloon,
Mm-hmm.
to perform pre-treatment
Mm-hmm.
again,
Mm-hmm.
and for the lesion preparation.
Okay.
Now we have finished the cutting balloon modification.
Mm-hmm.
Now we will perform the intravascular imaging
Okay.
again.
Sure. Okay.
Okay.
So I think that this is a very good choice for using the cutting balloon for this plaque modification, because compared to the other scoring balloons, cutting balloon is highly likely to cause less trauma to the vessel wall, because we know that the microblade, the working height is relatively low, so it's less likely compared to the NSE or the other balloons to cause very severe intima dissections. And here we can see as they start out the pulling back, once again we confirm it's over 3.5 vessel. It's nearly 3.8 maybe by the visual estimation. Again, after the cutting balloon modification, we can see that the plaque, it seems to be that the instant lumen gain is relatively good. However, one thing that I worry about is it's extremely eccentric plaque, which is not so friendly for the stent expansion, because under this kind of situation, this kind of a very high plaque burden, and especially it's eccentric, it's highly likely to cause the stent expansion, resulted in the ovule shape, which we do not want to see. So maybe we need to continue this pullback, yes, to see the proximal and ostium of the RCA. Okay, we have engaged to the guiding catheter. I
Okay.
think that Professor Gong, we have made some progress in the modification, but however, we can see here is how to say some composite fibrotic plaque, maybe a little bit calcification on the superficial, intima. Maybe I think that's more maybe using an NSE or an NC balloon to make further dilation of this part.
Oh,
Otherwise, that I worry about the stent expansion of this site.
okay.
Or
Mm,
maybe once again for the cutting balloon is fine, maybe.
okay.
So we need to dilate
Next,
two more time.
we will choose NC balloon,
Okay.
and the size will be bigger than the cutting balloon
Okay.
to modify the lesion again.
hmm So for this case, that we noticed Professor Gong choose the antegrade, approach first, because for my understanding that this is, occluded segment is at the proximal part of the RCA, so favors for the antegrade approach, and also the occluded segment doesn't seem to be very long due to the bilateral angiography. However, I think that potential, backup plan should be considered for this patient. So, Professor Gong, if the antegrade doesn't work so well, what's your backup plan? Other strategies for this patient. Do you consider ADR for this one?
Of course. If the initial line entering the subintimal space, next we will consider the um, parallel wiring
Mm-hmm.
or the stringery-based ADR technique.
Mm-hmm.
And if all this fail,
Mm-hmm.
we will transfer to the retrograde
Okay.
approach
Okay.
according to the segment uh, collateral.
Okay. Thank you. Actually, so I think that we need to explain something because we noticed that several audience from the online, we have some questions about our strategies for this patient. One thing is that we noticed that there is a guiding catheter of the left coronary artery. I think it's EBU, maybe guiding catheter or for the left coronary artery, or BL catheter. And we noticed that there is a wire in the LED. So why do we put a guiding catheter for the left coronary artery? One thing is that we use it as an bilateral, angiography tool, so that we can confirm the anterior wire position, just like Professor Gong just did. So that you can see whenever a CTO wire passes through the CTO segment, it's hard to identify the distal part, whether it's in the true lumen or not. Yes, you can perform tip injection. However, we need to emphasize that this kind of procedure is of a high potential risk to cause, for example, hematoma dissection if the distal wire is not in the true lumen. So the bilateral angiography using the uh, contralateral angiography is
3.25
relatively safe.
inseparable.
So we are keeping the BL guiding catheter in the left coronary artery as an how to say that help to identify the distal wear position. And the next thing is that keeping an wire in the LED is also very helpful because you need to make some preparation in the potential some risk. For example, the left coronary artery guiding catheter cause some trouble, for example, the section hematoma. So keeping an aware in the LED helps maintain the coaxial position of the getting catheter, make it stable, and also avoids the further potential risk factors.
Yeah.
And why do you have the let me see the questions from the audience. Did you perform
20.
the 3D reconstruction of the CTO? Actually, we didn't because of this patient is just admitted to our center, and you may notice that in our slide we didn't involve the angiography because this is a fresh patient. I think that this patient is
20.
just admitted to our center, and so this is not an staged PCI, so we didn't have enough time to perform 3D reconstruction because we didn't perform the CTA angiography before this procedure. However, during this stage, the PCI, we try to make very detailed plan for the CTO procedures because we perform CT angiography and other tests before the CTO cases. Whenever we notice that he is a CTO, but for this patient, we do not know.
Yes.
And would you like to explain which kind of devices are you going to use and why? Okay, I think Professor Gong has just made some explanation, and we noticed that for the integrate approach,
No.
we first use an filter family wire. And Professor Gong just explained why, because a filter family wire is an hydrophilic coated, and it's a composite core wire with a very good maneuverability and also torque responsibility. So I think that it is how to say almost the first relatively not so hard. It's less likely to goes into the subintimal space, and also it's a very good responsibility to help you to identify the plaque composition and also the response of the plaque. And also another question is that what's your routine wear escalation? Which is your wear number one, number two, and then number three? Okay, so we can see that we are making a third pullback from the RCA. This is after the NC balloon dilation, right?
Yeah. Is the 3.25 NC balloon
Okay.
with 20 ATM.
So We can see that initiate lumen gain is relatively very, obvious. I think this is a relatively very good example for the audience. First thing is that we use a cutting balloon, to make some controlled, very tiny dissection for the intima. And then we use the NC balloon to dilate the plaque burden to help the intima to make some controlled dissection. This makes sense, I think.
In fact, the plaque extended to the ostium of the
Hmm.
RCA. Professor Cao, what's your option if we should cover the uh, lesion to the ostium of the RCA?
Actually, at the beginning of this procedure, our initial pullback, I noticed that there is some plaque burden at the ostium. However, let me try to measure the plaque burden. Okay, it's a 57%, so it's within the. I think it's within our estimation. If there is no, change after the first stent implantation, I think that is safe to defer this one. The lumen area is enough, and also the plaque burden is not so high. I think that it's safe to defer this one. The lumen area is 8. So maybe we focus on our stake to our initial plan. It's a 3.5 by 26 or 28 something. And
Okay,
we make, further pullback to check the proximal part.
okay.
Currently, it's fine.
Okay. Now
So,
we will uh, uh, implant the stent
mhm. So it's a 3.5 by,
by uh, 13.3.
okay. So here is another question. What's a routine wear escalation plan? I think that the first choice is always, majority of the time is always a fielder family wear. And then we may make some wear escalation according to the situation of the plaque. If it's relatively very hard, very dense with calcification, so maybe
A
an
little
Gaia family
contrast.
wear is a good choice. And then, if the penetration with the Gaia family doesn't work very well, maybe potential the uh, I mean,
Okay,
the
well,
CP12
oh,
and other very stiff wear is a
only
good
a
choice.
little contrast.
However,
Okay,
sometimes that the wear
okay,
escalation is one choice. Sometimes we need to switch to relatively softer and relatively more safe, strategies. For example, the
okay,
fielder XTR, etc. But it's according to the situation. Sometimes when it's very torturous with how to say potential the macro channels, so maybe relatively softer, good maneuverability and good response where is a good choice. So we can see that Professor Gong has implanted the first stent, and according to the angio, it seems to be well expanded. And according to the
okay,
consensus of the European guidelines, that stent expansion should avoid in the landing as the relatively not so normal segment, which means the plaque burden is over 50%. However, from the IVS imaging, we notice that there is a relatively normal segment of the proximal landing zone, so we can avoid to land on the plaque burden with over 50%. And also, we noticed that there are several risk factors of this patient, for example, the hypertension, smoking. So good medication is a relatively very important basic for this patient.
okay. Next, we will perform the IVAS again
Okay.
to assessment if the position and the expansion of the
Okay.
stent.
Okay, now we are making a pullback to check the stand situation of the RCA. So what atmosphere did you use to open the stand?
Okay. Mhm.
I think we can, yes, dilate more.
Yeah.
I can check later. Maybe it seems to be relatively larger compared to 3.5 because we know majority of the CTO lesions after initial recanalization, the artery seems to be a little bit spasm, and also the lumen diameter could get larger after we open the vessel. Maybe due to the long time, without perfume. Okay, I think that proximal landing zone is perfect. There is no dissection, no hematoma. Again, the proximal plaque doesn't seem to be any change. Okay, let me stop the pullback. For the distal part,
Yeah.
and my suggestion is that maybe 3.5, yes, 3.5 again, NC balloon, maybe at a relatively larger atmosphere, higher pressure. The mid part is 3.7, so maybe 18 something for the mid distal part of the stent.
3.75
Okay.
with 28, yeah.
Mm-hmm.
And then we'll perform EVAS again.
Mm-hmm. I think this is a relatively good demonstration because we notice this is a relatively complex case with CTO on the RCA and a focal severe stenosis as the bifurcation of the ostium diagonal. And Professor Gong just indicated that later we will use our, domestic catheter-based FFR software to measure the function. I mean, I mean, function. FFR for the diagonal branch.
Okay.
And this software is a microcatheter-based FFR. It's relatively easy because the majority of the time we know that the wire-based FFR is of potential risk and troublesome to put the wire into a relatively torturous, especially under this kind of situation with stent crossing over to cover the ostium of the diagonal. So a microcatheter-based FFR device is easy to use because you can send it through a working horsepower. You do not need to draw back the working horsepower, and also it's easy to manipulate. And this software is 100% made in China. It's developed by the Beijing company, which is also in China. Okay, we can see that Professor Gong is making the post dilation.
Okay. A little contrast.
Okay.
A little contrast.
I think it's much better already.
Okay.
I think this is a clean and very quick recanalization of the CTO. It's a good demonstration with well-planned strategies and well choice of the right wire and also the strategies. And we are making the IVOS one more time to check the situation of the RCA after the NC balloon dilation. And I'm often asked what kind of stent, how to say, optimization is a goal to maintain the good prognosis for the patient. I think the key information, what intravascular imaging taught us, is a well stent expansion is a whole idea to, promise for the prognosis of the patient. To acquire this one, we need to choose the right, device, and also using the relatively enough and sufficient plaque modification is the whole idea. We can see again after NC balloon dilation, we can see the stent is well expanded. It's all attached to the vessel wall without any malposition, without dissection. And also here seems to be the most severe stenosis part with eccentric plaque burden. We noticed that after cutting balloon combined with NC balloon modification, the plaque burden has been well controlled and dissected. So we can see the stent is a perfect, circle. It's instead of an oval shape, just like I introduced. Maybe we continue this pullback to see the proximal part of the RCA. Okay. I think the whole stent is well expanded. Let me check again for the detailed information.
Okay, 我看一下。
Okay, once again, the distal edge is fine. Okay, distal edge is perfect. Let me measure the MSA. The MSA is over 8.6. I think this is enough.
Okay, I
Mhm.
will to check the off term of the RCA.
Okay. From this one, doesn't seems to be any, I mean, severe damage to the ostium of the RCA.
Okay,
The lumen is enough.
I will perform a new recorder for
Okay.
the off term.
Yes,
A
because
new
we didn't
record.
see the.
Can you get
Okay, sure.
build a new run?
Okay. Okay. Maybe you want to engage a little bit. Okay, pulling back.
Okay.
Mm-hmm.
It's very good.
Yes.
No
Yes.
defects.
Yes.
Now,
Everything is good.
then I will finish
Mm-hmm.
the. Okay.
Okay.
And then we will perform IVAS and FFR examination for
Mm-hmm.
the ofteo leading of the first diagonal.
Okay. And one thing for your information is that we noticed there is a focal mild stenosis as a mid part of the RCA. And Professor Gong has using the IVUS to check the plaque burden and also the lumen area for that site. It's I mean, benign lesion. It doesn't need the revascularization. So it's just one thing for your information.
Okay. I see the final
Mm-hmm.
coronary angiography.
Okay, perfect, I think. And also the distal perfusion is much better compared to the original. So I think that this patient is going to, I mean, symptoms is relief very much because we can see the perfusion or the RCA is a large vessel. It's a red dominant. Okay,
Okay.
perfect. Perfect one, I think. Okay, I think we switch to the RAD, diagonal bifurcation lesion.
Yeah.
I think this is a good chance because we have the IVUS on the table for the RCA recanalization. And we are going to perform the function test FFR, microcatheter based FFR for the diagonal. So later we are first try to use the IVI system to measure the minimum lumen area of the diagonal branch, and then we use FFR to test. So this is a good comparison. What's the result of the IVI system minimum lumen area? I mean cutoff value to predict whether there is ischemia or not. And on the other hand is function test, the physiology evaluation for the diagonal branch.
You mean a
So I think
new?
that this is an internal question, whether to use the IVUS or the FFR to identify or to evaluate the intermediate lesion, whether it's need to be treated or not. So I think this is a good chance for us to have a direct view. I mean, how to perform it and how to treat it. And finally, I mean, to answer the initial question, for the intermediate lesion, which kind of devices should be used? What's the best choice?
Okay. 你可以用右管。I see.
And from the angiography, I noticed that maybe it's a provisional stenting. I think this strategy 10 years ago.
Can you give
And
me a little
we noticed that
context?
there is no stent at the ostium of the diagonal. However, that the stent seems to be crossed over to cover the ostium of the diagonal branch. So that's if they didn't perform the kissing strategies, I think that there is some difficulty in passing through the FFR microcatheter. And later we may check. It's a relatively very big diagonal branch, and we know that keep open to maintain the recanalization, to maintain the important bifurcation, for the set branch for the bifurcation lesions is of key importance, because if the bifurcation is how to say mm, the isolate diagonal. For example, like this patient, he has only one diagonal branch, and
A
then we
little
need to keep
contrast.
it
A
open
little.
because it's of great importance. And if,
Okay.
for example, the bifurcation, for example, diagonal is
A
not so
little
long,
contrast.
and also the diameter is not so big, for example, it's less than 2 millimeter in diameter, the length is less than 70 millimeter, so maybe it's not so important because the perfume myocardium is less than 10% of the left ventricular. Okay, we can see that Professor Gong is going to perform the IVUS first for the diagonal branch. So let's see if the catheter can pass through very smoothly, because we do not know they perform casing for this bifurcation or not. So there might be some potential resistance in passing through the microcatheter. Okay, let's hope it can pass through smoothly. Okay, it passed through. Good. I think we are lucky. Okay. Pulling back. This is a pullback from the diagonal branch. It's 2 point maybe 5 something. Yes, 2.5. The stent distal edge doesn't seem to be well expanded. I think we can see the distal reference lumen is almost 275 something, but here the stent is not so well expanded. Okay, this is, oh, I think it's relatively very severe. I think they perform casing strategies because I don't see the stent stress in the ostium of the diagonal branch. And the stenosis of the ostium of the diagonal branch is relatively very focal and severe. Later I may measure the minimum lumen area. Okay, maybe we stop the
Okay.
pullback. Okay, let me measure the MLA and also the lesion length of the diagonal branch. Okay, once again, this is a distal reference of the diagonal branch. It's, let me see, something 2.3. Okay, fine, I think. 2.3, and this stent, the MSA, let me see, 1, 2, 3.
Yeah. The imaging transferred to the.
Okay, it seems to be 3.9. I think that it can require a little bit of post-dilation later. And this is the ostium of the diagonal branch. I think it's, I
Clearly.
mean, initiated on purpose
Oh,
to, I mean, leave this ostium of the diagonal
clear,
branch.
clear. Okay. Just.
The minimum lumen area is 2.8, 3.1 maybe something, 3.0. Lesion length is relatively very
Clear.
short.
Clearly. Okay.
Lesion length is very short, maybe 2 to 3 millimeter. So Professor Gong, can you make an attempt what the FFR value is going to be?
uh,
The
Now
mhm.
we will just to perform FFR
Okay.
assessment or
Mhm.
FFR measurement
Mhm.
using our domestic product. That means the uh, microcast.
Microcaster based FFR.
Yes,
Yes.
based FFR.
So Professor Sun Hui, what's your guess for the FFR value? What do you think it's going to be?
In more than 0.8.
You can
Okay,
see the MRA is over 3 millimeter square, so it's not so severe.
of course.
Okay, we are performing the equalization.
Yeah.
Once again, I introduced that this is a microcaster-based FFR, so it's of
Give me a little
very
contrast.
great convenient for the clinical usage.
Okay. Yeah. equalization.
Yes, he's doing it. Did we flush the getting caster using saline?
Okay.
Okay.
Very good.
Okay.
Next. Okay.
Can we see the FFR screen? Okay.
A little contrast.
Okay, you can see the microcaster was sent through the stenosis very smoothly to the distal part of the diagonal branch. So this is one of the advantage of the microcaster-based FFR, I think, because you can use it on a working horse wire. So you can do it frequently, and also do not worry that the FFR wire is passing through with a difficulty.
Okay.
I think that the resting PTPA is 0.93, so it's hard to say. We know that the cutoff value for the resting PTPA is 0.92, so we can tell this is a very focal, very short, stenosis at the diagonal ostium. What the FFR value is going to be. According to the intravascular imaging, like IVUS, we have multiple minimum lumen area cutoff values to predict ischemia for clinical usage. However, there is no, one cutoff value that is agreed by all the experts, and we make consensus on this one because a different vessel has a different area of myocardial perfusion. And so this kind of a diagonal is relatively very big. We can see the distal reference size is 2.3 or 2.5. It's a big vessel. And also this kind of ostium severe stenosis is of potential risk for ischemia. So we are using the IV adenosine, I think, that for the hyperemia. And we notice that the blood pressure has been dropped to 99 average. And the FFR value is okay, it's a 1 minute and 20 seconds. The FFR value is 0.3, I think. Later we may check. 停吗？
等
嗯
Just a moment.
它药已经停了。再给一会儿吗？再给一会儿吗？
是 Yeah. Go back.
Okay, pull back, please. Okay, it seems to be 0.3, 0.5. 还要再给一会儿吗？万一一会儿他说再不够时间啥，还用吗？
再来一次。Again.
Okay, 再给药。So maybe we try to increase the adenosine dosage and to make a second attempt. Okay, recording. We have just increased the adenosine, dosage to increase the hyperemia to confirm again whether the it's positive for the ischemia or not. And this time we are going to record for 2 minutes, and we have just increased the adenosine dosage. I think that one very important teach point for observing the FFR value is that we need to mark, we need to watch, to focus on the stable lowest value of the FFR value. However, it's not the lowest. Sometimes after the initiation of the adenosine, the the drop of the coronary artery pressure and also the pressure in the aorta is not matched, which means that
back.
There is a very quick drop after the initiation.
PD.
Putting. So we are recording the stable lowest, not the lowest value.
No. It's the one.
Yes, almost 1.0.
No.
Almost 1.0. Okay, I think that there is no drift. Okay, almost 1.0.
Very good.
Okay.
There is no drift. 1 is 0.85.
Let me check again for the
0.85.
Yes, I think that the two maritimes the same value. The first time is 0.5. The second is also 0.5.
Okay.
0.85. 0.85. It's very stable and there is no drift for the 2 times measurement. I think that this one meets the cutoff value for the IOS image also because we notice the MRA is 3.0
Yeah.
and also the lesion length is relatively short.
And for the lesion, we should choose MDT.
We defer this focal lesion.
Yes.
I think this is a good demonstration because from the angiography, I think that majority of the operator will worry whether it's a positive lesion and whether need to perform the very complex strategies or not. However, for the FFR value, we can see that yes, it's benign. We do not need to perform the revascularization. I think this is a good demonstration for this one.
Okay. And the last step, we will perform IVL imaging for the previous denting the LED.
Okay.
Then we will finish the procedure.
Okay. So although it's stent put 10 years ago, but from the pulling back at the proximal part of the RAD, I think that is well, I mean, covered by the intima. It doesn't seem to be any severe instant restant. On RCA progress very fast. So I think that we should recommend the patient to quit smoking and also control the hypertension and also maybe potential hyperlipidemia. So hyperlipidemia. Okay, pulling back.
Yeah.
Okay, once again, we are making the pullback to check the stent from the RAD. Once again, there is, I mean, mild plaque burden at the mid distal part of RAD with some intima calcification. Okay, once again, the distal edge of the stent is well expanded. I mean, no neuroatherosclerosis. So which means that the PCI for this patient is, I mean, very friendly. So we do not see some target lesion failure. And also we have just passed the diagonal branch. And we can see the ostium of the diagonal branch is very focal severe stenosis. And after FFR, I think maybe we give some natural after the Evans pullback to make the final angiography.
Okay.
The stent is well expanded. No ISR, signs of ISR.
I think in this case, we are finished. I think I will finish the procedure today. For this case, we use the intravascular imaging and functional assessment to optimal our procedure result for this CTO and and integrate and leading. Okay. And with the guide of the IVAS and FFR, which will help us to make precise decision and to get the final optimal result. I think this is the future of the PCI, and it will take good and long good result, clinical result for patients. Okay.
Okay. Thank you. So, Professor Gong, one question from the audience. So, what's your wear escalation strategies? For example, for the anti-grid, your first choice in this case is a fielder family wear. If the fielder, I mean, wear failed, so what's your second attempt? I mean, for example, what's your next choice of the anti-grid wear?
Okay, for this case, according to the present experience, if the feedback fails, then we will exchange the mouth diff
Mm-hmm.
and no hypertrophic,
Mm-hmm.
no polymer jacket,
Mm-hmm. Mm-hmm.
uh,
Bare metal
yeah,
wear, you mean? Yes.
and with tapered tape
Mm-hmm.
and with mild stiff
Mm-hmm.
or moderate stiff,
Mm-hmm.
such as the Gaia
Mm-hmm.
and Gaia Next and Judo
Mm-hmm.
Theory Y.
Mm-hmm.
And if the calcification lesion, I think of the uh, uh, penetration
Mm-hmm.
is very important.
Okay.
Then the Conquest Pro
Mm-hmm.
theory Y will be used
Okay.
to penetration the calcification proximal cap.
Okay. Thank you, Professor Gong. I think that we are going to perform the final angiography for the LAD. Okay. Once again, seems to be fine. Although from the angiography, the ostium stenosis
Yeah, yes.
although from the angiography, it seems to be very focal severe stenosis, but we have just performed the FFR, and
Spasm.
also the I
The
was
often is spasm
indicated that
to give
the
me
minimum
yeah.
lumen area is over 3 millimeters square, so we do not worry too much about the diagonal. However, we emphasize that a good medical therapy for this patient is a base, and so we need to make some well-controlled blood pressure, the lipid, and also quick smoking to suggest the patient. And after some vasodilator, we are going to repeat the angiography to see the situation of the whole vessel from the left coronary artery.
Okay. Okay.
Okay, it's a very big
Do you
diagonal
still
branch.
spasm?
I think it's get much better, and I think from FFR, it's a TIMI3 flow. We do not worry too much, I think.
Yeah.
And if we have time, I think 那个兄弟呢？那个兄弟呢？ I think that we have some time. Maybe we give some introduction to this macrocaster-based FFR.
Okay. Okay. We'll finish.
I think it's a perfect demonstration.
Okay. 啊，那 Professor Cao can introduce the
嗯，
FFR.
让他把
Yeah.
镜头给对一下。
Okay.
So that we have some time left, and I think it's a good choice for us to make some introduction of the FFR, which is this is a microcaster-based FFR. I think that's some advantage of this. I mean, some 可以持续了，没事，不打。I think some advantage of this blood device need to be focused. One thing is that you can see it's a microcaster-based, and the diameter and also the size of this catheter is quite small. And our data for this microcatheter is that it's much smaller compared to the macrocatheter. 拿这个照我，要看我这个手，照我这个手，要看这个东西。哎，好，谢谢。So that you can see the microcatheter is so tiny, so we do not worry too much that the catheter is occupying the space and also the blocking the blood pressures from the proximal part, which means that this kind of device is superior to that of the wire-based FFR, which means that it doesn't, I mean, influence the accuracy and also the final result of this measurement. And I noticed that there is a similar device in the US, which is performed by the Assist company. However, I need to emphasize that this device is superior by the diameter and also the size of the catheter to the other product currently on the market of this microcatheter-based FFR. And also you may notice on the tip of this microcatheter there is a pressure sensitive devices to measure the pressure of the distal coronary artery and compared to the aortic pressure. So this is how do we perform this one, and it's a quick exchange system, that which means that you can put it on a working hardware with a relatively very rapid sending through the devices, and you can make some multiple measurements. For example, you can measure the diagonal, measure the LED, measure the RCA post stenting, because we know recently that the manuscript indicated that after stenting, the FFR value should be over 0.9%, 0.9, to make some promise to the prognosis of the patient. So I believe that this microcatheter-based FFR system is of a great convenience to the clinical usage, because with this one on the working hardware, you can measure almost all the vessels that you can wear with the working hardware. So this is of great clinical convenience for the clinical usage. This is our 100% domestic software. Okay, thank you. I think that this is, all for the current, case demonstration. Okay, thank you for your, concern. Main control, I think that we have finished the case. Thank you.